Well, thank you all for coming. I've enjoyed watching the names appear on Meetup. um, and so I guess I'll introduce myself. I work in a field called Biomedical Informatics, which focuses on really the application of information, much more so than technology, in healthcare and related areas. And like every other field, we've discovered big data. As Christian mentioned, I work up at OHSU. There's actually a department. We're actually, I can modestly say, one of the leading programs in the field, in our academic field. I tend to work more on the academic side than the healthcare delivery system side. So I don't do a lot with if you get your healthcare at OHSU, although I get mine there. Anyways, so Christian asked me to talk about big data in healthcare and biomedicine. And I will do that, and I will try to give you a balanced view because I know that many people, including myself, have a lot of enthusiasm about data science, big data, and all that. And there's certainly a lot of potential. But also, I think we need to be realistic on what we hope we can accomplish. And so I will try to tell you the good and the not so good. If you're interested in following up, I can be reached by email. I do check my Twitter feed. And I have a website where I've actually posted a PDF of these slides that not only has the slides, but also has all the references. You know, being an academic, I can't just tell you things. I have to give you the reference of where that came from. And I also blog. I write a blog called The Informatics Professor, and I talk about careers in informatics and topics related to data. It's another interest of mine. So let me proceed ahead. And what I'll do is I'll go through my slides. I tried not to have enough slides to fill the entire hour, so I'll be happy to take some questions at the end. In fact, that's usually my favorite part, so I'll do that. So my goal is to provide a balanced view. I was tempted to say fair and balanced, but I don't have those politics. So a balanced view of opportunities and limitations of big data in healthcare and biomedicine. So I'll talk about the growing data sources that are available, some of the opportunities for what we call secondary use or reuse of clinical data and electronic health record systems, which are primarily used to document patient care. But as the data is electronic, it provides opportunities to do other things with it. And then I'll talk about some of the caveats, and then I'll, it's not really a commercial, but I will tell you what's happening up at OHSU, because usually I find people are interested in that. So as you may know, there are problems in healthcare. Healthcare is not as good as it could be. There are problems with the quality of care that's delivered, studies showing that people don't always get the kinds of care that they should be getting, and sometimes get more care than they need. There's lots of safety issues in healthcare, medical errors, basically causing harms that result as a byproduct of medical care. We also have rising, not so much rising healthcare costs. We have high healthcare costs in the United States. We've actually managed to bend the cost curve somewhat over the last few years, and but still, by every measure, we spend way more on healthcare in the United States than in most other countries. And also inaccessible information. You may hope to think that your doctor has all the information on you, but oftentimes there's information in other places that's not accessible. So there's growing scientific studies, scientific evidence that things that we can do with IT systems can improve the quality of healthcare. If you look at this slide here, which shows different studies that have been done in different categories, and most of these studies show that there's positive benefits when you interject IT into the healthcare process. Sometimes you don't always see that benefit, but often you do. One of the challenges has been that there's not a lot of, well, a lot of the research that's been done has been done at academic centers that are on the leading edge of this sort of thing, and it's a challenge to get that out into the real world or into the rest of the world. So in order to expand the use of IT in healthcare, you may recall back around 2008, the economy started to tank, and there was a need to have an economic stimulus. And so part of that economic stimulus, about 30 billion out of the 780 some odd billion, actually went into basically incentive programs to increase the use of IT in healthcare. I was telling some folks earlier that if I had given this talk 5 or 7 years ago, I would have lamented that there is very little IT in healthcare. At that point, probably 95% of all transactions were still done via paper and fax. But that's actually changed quite significantly in the last 5 years. It may have happened anyways, but certainly the investment in something called the High-Tech Act, which was part of the American Recovery and Reinvestment Act, the stimulus bill, put forth this incentives for the use, and some of you may be familiar with the term meaningful use of health information technology. And in fact, when he took office, someone got President Obama's ear, and even before he was inaugurated, was talking about the need to increase the use of electronic health records. And actually, even before him, George W. Bush, in several State of the Union address talks, mentioned about the need for health information technology. So what is the result of all of that money that's gone into the adoption? Well, if you look at whether we're talking about office-based physicians, emergency departments, outpatient departments, and probably the most so even in hospitals, the growth of the use of electronic health records has increased substantially. And again, 5 or 7 years ago, I would have lamented that we're way behind the Europeans, the Australians, but we've managed to catch up to them. I think what really excites a lot of us who work in healthcare is this data. When all of the data 5, 10, many years before that was just sitting on paper, there's not a whole lot you can do with the data in terms of all these things I list here, which I'll go through in a moment. And back in 2007, we were talking about things like this. Well, now we actually have the potential to do things like this. So using data to improve the quality of the healthcare we deliver, enhancing research, this notion of translational research, of moving research out of labs into healthcare settings and into the community, public health, surveillance, and I'll talk about some of these things, and also this concept of the learning healthcare system. When an airplane goes down, the first thing that happens is the NTSB goes out and looks for data. You know, what went wrong. We don't really do that in healthcare. We don't learn much from what we do, in part because information data historically was sitting on paper records. But that's changed now, so there's potential for implementing what we call the learning health system. There's also been this concomitant growth in research data in healthcare, in medicine. The National Institutes of Health, which funds biomedical research in the United States, has a program called Clinical and Translational Science Award. It's basically in funding of infrastructure to facilitate research, and OHSU is one of the 60 universities nationwide that have been funded to enhance their research infrastructure to do research more effectively. What that's resulted in is things like research data warehouses, so starting to pull data from these clinical systems and put them into data warehouses, and really advancing this idea of secondary use. Another big area, and I'll go into all these in a little bit more detail in my next few slides, the kind of omics revolution that started with sequencing the genome and now has led to measurement of proteins and various kinds of metabolites that take place in living organisms, which gives us insights into the genetic causes of diseases and so forth. And if you read the newspapers, you may have heard the president and others talking about precision medicine, the idea that we have the ability to kind of measure down into things like the genome and other kinds of data, including electronic health record data, and so there's new opportunities. So now we can start to pull together all the kinds of things that happen in healthcare, simple demographics that, again, all this previously on paper, age, ethnicity, things like that, diagnoses, procedures that can get carried out with patients, notes, clinical notes that get captured, even though the challenges of natural language processing are probably a little more exacerbated in healthcare. All kinds of other information. So many institutions, including OHSU, have started to create these research data warehouses that are a wealth of information about patients and the healthcare that they get. And so some places, this is a figure that comes from a paper about Vanderbilt University's research infrastructure. They pull all this clinical information, again, the same things you saw on the last slide, demographics, medications. They pull it into a data warehouse. Some of the data they de-identify, that makes it a little easier to work with in terms of some of the legal and regulatory things. But sometimes you can't de-identify the data. You need to know, you need to be able to link across patient care episodes and things like that. So the data has to be identified. I also mentioned the falling costs of the sort of omics data, where some of us in this room were around when literally the first human genome was sequenced back in the late 90s for millions and millions of dollars. And now we have the ability to, the goal is to be able to sequence a genome for $1,000. So $1,000, someone could potentially take a specimen from you and identify all of basically your genome, all of the base pairs, for those of you who remember all that from high school biology. And interestingly enough, at least it's somewhat leveled off, but when the technology really started to come to the fore, it actually vastly exceeded Moore's law, the doubling of power in every 18 months. Although, again, it's leveled off. But we're pretty much to the point where we can, sequence a human genome and, potentially use it for healthcare. So I told you about the various kinds of data that are available. So I'm going to shift gears now and actually tell you some of the things we can do with this data. But then I'm going to come back and just to give you a little warning to talk about some of the caveats, why we can't completely depend on this data and actually need to be better at capturing it and figuring out what we're going to do with it. So I'll talk about these three areas on how we're actually using big data in health and biomedicine. So let me start with healthcare. There's many ways that we're using data to improve healthcare. Now, one of the challenges with healthcare that has nothing to do with data is how we pay for it. And we've historically paid for healthcare by reimbursing the healthcare system, physicians, hospitals, for the things that they do. Whatever they do, they submit the bill to the insurance company, whether it's a private insurance company or a government insurance like Medicare or Medicaid. And when in that sort of setting, there isn't a real lot of incentive to track what you're doing and seeing how well you can do it better, because you just do something and then you get paid for it. Well, so the reimbursement, the payment model in healthcare is shifting. We need to think more about the value that gets provided. Are we providing the proper care? Are patients actually getting better? So some people call this shifting from volume to value. And when you start to shift to value, for example, our recently departed governor, who actually unfortunately had a lot of really good things that he did about healthcare, although his maybe judgment with some of the other things wasn't as good. But certainly in terms of healthcare, and he was a big proponent of this, and the healthcare reform that went on here in Oregon really kind of tried to move in this direction. So, for example, instead of just everyone submitting a bill for what they did, you give the healthcare system a fixed amount of money. You know, this is how much it typically costs to treat a person who needs a coronary bypass operation. And when you shift that payment approach, again, all of a sudden, data becomes important, because you want to make sure that you're not wasting money, that the patient's getting the best care. And so you start to see the value for data. And then this gets into the whole area of predictive analytics, which I'm sure is a topic familiar to many of you. How is it used in healthcare? Well, so for example, if you get a fixed amount of money to care for a patient, one of the most expensive things that happens in healthcare is when people go into the hospital. Hospitals are inherently expensive. If you can keep someone out of the hospital, you can save a lot of money. And in fact, the government, through the Medicare program, has noted how many, especially elderly people with multiple chronic illnesses, are frequently being readmitted to the hospital. In fact, they've actually started to lower or basically give healthcare systems penalties when too many patients go back into the hospital. So now you want to be able to predict who those patients are who might be going back to the hospital. And so people have looked at different algorithms, pulling on different kinds of data and seeing how you can predict that thing. Whether or not this is big data, big data is sort of a nebulous term, but it's certainly using data and using it in ways that healthcare hasn't before. And another way that data is being used to improve healthcare is to look at the things that happen to patients, whether they're getting the appropriate tests that they should be getting, preventive measures, whether they're getting follow-up on various aspects of diseases. If they're a patient who has diabetes or congestive heart failure, are they getting certain tests that they should be getting? So this is how we use data to improve healthcare. You can argue whether or not it's big data, but it's certainly the use of data. I apologize for this busy slide, but another area that is very data intensive is what we call genome-wide association studies. And the idea here is that when you start to know a lot about patients and then you start to sequence their genome, you find different areas of their genome that might have variations out of proportion to people who don't have a certain disease. So what these are actually the different human chromosomes here, and what the circles represent and you can go get this slide if you want to zoom in on it. I'm not going to zoom in on it, but you can look, and there are different organ systems that have different diseases. And so, chromosome 1, has all of these studies that have been done that have correlated certain diseases or other kinds of what we sometimes call phenotypes with certain variations in areas of the genome. And, of course, these are correlations. I'm going to come back to this because, the old correlation doesn't mean causality. But the point is that many of these studies have been done now and have shown that people who have various, again, diagnoses or other kinds of conditions, you can find that they vary in areas of their genome. Does that, no one, that doesn't necessarily tell you the cause and effect, but it does tell you that there are some differences. If someone has a certain variation, we all vary slightly in our genome. I mean, we all have roughly the same genome. That's why we're humans. But because of different hair color, height, various kinds of things, we vary in these different places, and that may be associated with different diseases, but that doesn't necessarily mean that there's a connection between the disease, but the cause and effect may be more complex than just you have a variation here, you're gonna develop diabetes or something like that. And so some research groups have attempted to tie together the genome data with the data in the medical record. And there's a project at multiple centers, Vanderbilt University, Northwestern, Marshfield Clinic, Mayo Clinic, a few others, that called the eMERGE network, that have tried to process the phenotype, the diseases and symptoms and findings that people have documented in their medical, those genomic variations. And they've certainly found a lot. Another area for potential is to is to be able to conduct clinical studies. If you have a population of 1 million people and different people were treated in different ways, you can potentially generate knowledge, if you will, from the information that you find. Although we'll come back to this in a moment, and it doesn't obviate the need to do these randomized controlled trials, as we call them, but they can complement them. Another area is public health. This area changed quite a bit after September 11th, 2001, when it was apparent when it had potential adverse things that could happen, and it's this whole area of trying to identify early detection of bioterrorism or even natural kinds of events is called syndromic surveillance. And the idea is that you're looking for things that might tip you off that someone released anthrax into the air or contaminated the water supply. And obviously this area took off after 9/11. And then we have all this data. Now that everything's digital, we know what medicines people buy over the counter. We know what terms they type into search engines like Google. And there's a lot of data that we can use to potentially discover that an epidemic is happening, again, whether it's man-made or natural. And there's usually with these epidemics, the sooner that you intervene, the sooner you can kind of head off the spread, et cetera. And not surprisingly, Google kind of picked up on this, and some of you may have heard of Google flu trends, which basically can kind of predict the flu. and it actually does it pretty well, although there's a couple limitations. One is that, Google's constantly tweaking its algorithm, so the accuracy of the algorithm changes over time. But probably the even bigger problem is that when it comes to the flu, the flu spreads pretty rapidly through populations, and actually most people, who get the flu do fine, except elderly and people who have chronic illnesses. And so you can get this data, but there's not a whole lot you can do with it. But again, the idea behind syndromic surveillance is that there might be conditions that you could detect earlier. And in fact, the kind of downgrading of the performance of Google Flu Trends, like a lot of things, there was a lot of hype around it, has led some people to say, well, we need to avoid big data hubris. We can predict things, but we need to be careful in terms of what we can claim we can do with that data. So I've been through on the last few slides some of the areas of healthcare, biomedicine, where the potential for using data, including big data, is real. What I'd like to talk about next is just some of the limitations of this. Some in the audience come from healthcare backgrounds and will appreciate this more. There was so much hype about big data that a number of my colleagues and I thought, we're enthusiasts about data. We see all the value for it, although we can't oversell it. That's always a problem with technology. It's always a problem with healthcare, maybe with everything else. And so we actually wrote a paper that was published in a journal you've probably never heard of, called Medical Care. But what are the limitations of using medical records for in this case, we said comparative effectiveness research, but really any kind of secondary use of data. Well, one problem, medical records aren't always accurate. Either the physician misinterprets something, the patient says something that's not quite true. There's other lab tests sometimes are inaccurate and so forth. Data might be incomplete. People get their medical care in a number of different places, and so you may not have all of the data on a given patient. Sometimes the data gets transformed. Probably the best example of this is that many physicians and hospitals will organize the data, present the data in a way that will maximize their reimbursement, which is great for the bottom line of the hospital, but might not be good if you're wanting to do interesting analysis with the data. Sometimes the data is uncoverable for research, particularly a lot of healthcare data is in documents and notes, progress notes, discharge summaries. And even though we're getting better at natural language understanding, there's a lot of kind of things that are written between the lines that people in healthcare know, but NLP algorithms don't necessarily pick up. Data is of unknown provenance. Some of you who work in data science are, I'm sure, familiar with the term provenance, where how believable is our data? So, a good example of this is a medication. So, physician might prescribe a medication, and he or she will write down in the chart, patient given a prescription for amoxicillin, 255 milligrams, 3 times a day for 10 days. Well, they might write that down, but somehow the patient might not get the prescription, or if the patient gets the prescription, they may not take it to the pharmacy, or if they do take it to the pharmacy, they may not come back for it, or if they do come back for it, they may not take it. So, just because that physician at the front end of the process had written down, I'm going to prescribe this medication, there's several steps along the way that need to occur to make sure that the patient actually took it. There's issues of granularity where sometimes people talk in general terms and not specific enough. And then information, data in medical records is sometimes incompatible with research protocols. People, physicians may make a decision, prescribe something that really isn't supported by the best research. A few other comments about the clinical data in medical charts. Documentation is not always a priority for busy physicians and others in healthcare. Oftentimes, as I've sometimes said, it's finishing your documentation is what stands between your workday and going home for dinner. And so they may take shortcuts in terms of getting data into the patient chart. There's also this term that this phenomenon statisticians call it censoring. Not that they're like deliberately censoring something, but not every bit of information is recorded at every visit. So a patient might have a diagnosis, but it might not make it into the chart at that particular visit because they were dealing with something else. So just because something's not there doesn't mean that the patient didn't have a disease. And sometimes patients get their care elsewhere, and so we have this phenomenon of censoring. And this is why I sometimes people who for example, identify all the patients who have diabetes, which is a fairly common disease. It's one that is relatively straightforward to diagnosing, but people have done studies at how accurate you can be in identifying in a large group of patients how many have diabetes from their medical records. And it's reasonably well, 90, 95%, but it's not 100%. And so if you're doing some kind of study, some kind of analysis, you might not capture it all. That we also talked about in this paper we wrote about idiosyncrasies. So coming back to this concept of censoring. So sometimes patients get some of their care at one place and then they move, and you don't necessarily have all their data. This is relatively common at a place like OHSU, where people come for specialty care. And then, so that's left censoring because the data that you're missing is prior. Then there's right censoring. Someone just developed a new illness, and they may not have developed all the symptoms that might occur in this particular disease. Data also sometimes just doesn't get captured. Again, they may get their care elsewhere, or people buy drugs over the counter, or even worse, people go to other countries that don't control prescribed drugs as well as we do. So they buy antibiotics over the counter and things like that. So we don't necessarily know everything that's been involved with their care. When I say bias in testing and treatment, that's again, physicians don't always adhere to what the latest or best scientific evidence is. There's a lot of variations in how physicians practice in terms of ordering tests and things like that, and then inconsistent use of coding and standards. So a big problem with healthcare data is interoperable data. And I told you that I write a blog, and this is a topic of great interest to me. And so the first of these came about when someone else's blog, someone said, we need to have a universal electronic health record. Everyone should use the same system. And I actually disagreed with that, although what I strongly believe is that everyone should use the same data standards. We should call things by the same names, format data in the same way, and then, build, let different vendors, others build, different types of electronic health record systems on top of that foundation of interoperable data. Another thing came about. I was in a meeting at OHSU, and there was a vendor there who wanted to help the cancer center, the Knight Cancer Institute. Probably most of you have heard of it. They get a lot of referrals, and when patients come, in this day and age, they tend to have basically scanned PDFs of their records sent. And so this vendor had, OCR and NLP software. We can reconstitute your data. And most of that data actually started out in structured electronic forms in laboratory systems. And to me, it was like unscrambling eggs. Why would you and of course the Cancer Center had no choice because that's how they get the data. But to me, it's kind of an indictment of our system when you have structured data that gets printed out on a piece of paper, scanned back into electronic form, and then gets sent to another healthcare institution. So we need to avoid the need to unscramble eggs. But there's a challenge with structured data. Everyone who works with data knows the more structure we have with data, the more consistent and reliable it is. The problem is that physicians, other clinical people, really don't like structured data. They don't like checking boxes. They think it kind of constrains the story that they want to tell about the patient. And this has actually turned out to be a more challenging problem than anyone anticipated. That's why I call it the conundrum. And just the idea that, while it would be great if we could structure all of the data that came into our information systems in healthcare, the reality is that many who take care of patients would rather tell the story and all the nuances and so forth. And those nuances are there. And I don't think we anticipated that as enough or we appreciated it enough when we started going down this path. But there are a lot of efforts going on to make healthcare data more interoperable. The Office of the National Coordinator for Health IT, which is the kind of lead federal agency on health IT systems, has been focusing their efforts lately on interoperable systems, things like bringing the way we move data between systems into more modern terms, like using RESTful architectures, modern security standards, and having standard APIs so we can query different systems. Right now, we literally have this Tower of Babel. So, we've achieved that 70, 80, 95% electronic data, but it's very difficult to move data between systems. Even if you can physically move the bits, getting it into the same format and in a structured, standardized way has been challenged. So there's a new standard that those who work in health IT probably know about that will at least start to move us down this path towards more standardized ways of moving data. We also need to establish research networks, so collecting data in repositories, and there's a number of established research networks. Kaiser, just across the river, has been part of the HMO research network for many years, and the FDA, which is among their many tasks, is to monitor safety of drugs that they've approved, has been moving that direction. And then there's a new project called PCORNet. PCOR stands for Patient-Centered Outcomes Research, where these clinical data research networks are being built and will be aggregating data under a common data model. So again, helping us to have some of this more structured, standardized data that we can start to do things with. I also wanted to make a comment. So again, some people say, oh yeah, we just pour all the data into electronic systems and turn the crank and out comes medical knowledge. It's not quite so simple. We still need to do things like clinical trials, particularly for new things. Clinical trials, for those of you who don't know, will typically try to keep everything constant except some, one treatment or another to see if people get better. And there's still a need to do those sorts of things because just because something's new, this is actually a figure from an article in the New England Journal of Medicine, just looking at how many times something new actually turned out to be better. And it happens quite a bit, but there's also times that it doesn't. The old treatment is just as good, or sometimes the new treatment is even worse. And there's also been some criticisms of these genome-wide association studies that I mentioned a number of slides back, in that we have, again, just because there's a correlation with something doesn't mean there's a causation. So we identify a gene variant that seems to be more prevalent in people who have a certain type of heart disease. Well, that's good, but can we really understand why that's the case? Can we use that to develop a treatment? Is it just some sort of spurious association, or maybe there's a confounding factor? So just because we have all these correlations doesn't that's not the end of the story. We then have to go further to explore why that might be the case. There's one other concern. I actually put a question on the meetup thing saying, what do people want me to talk about? And this is the one topic, and I had planned to talk about this topic. So we have all this healthcare data, some of the most sensitive information about ourselves. And I even though I've told you about some of the negatives, I think, you know, the net is positive, and we can do lots of interesting things. But as we know in our current society, you know, there's lots of people that can figure out lots of things about us, you know, especially these things we carry around in our pockets now that track where we are and what we buy and what we're reading and things like that. And, you know, of course, in healthcare, again, this is some of the most personal, sensitive data. So we need to be concerned about this. And, you know, we need laws and regulations. We need a culture around protecting privacy in order to be able to do the kinds of good things we think we can do. This has actually been a problem for quite some time. There was a famous story, and I actually know LaTanya Sweeney. She was actually a graduate student at MIT, and she, at that time, the state of Massachusetts used to release the database of the de-identified database of all of the state employees and their healthcare utilization. And then she went and got the voter registration rolls from Cambridge, Massachusetts, which were also freely available. And she was able to connect as a 50-something-year-old man who lived in a certain zip code. And it was the governor of Massachusetts, William Weld, was the governor in the mid-90s. And she was able to essentially identify all of his healthcare utilization from this public database. That was kind of the first instance of this. We know now that we can identify a lot more. Another challenge is that as we put more and more of our data in electronic forms, healthcare institutions, well, rank low, maybe not at the bottom, but rank pretty low in terms of protecting data. Healthcare institutions are so busy with all kinds of data, with you know, barely making enough margins to stay in business, don't really have a lot of resources to invest in security, although they're having to now, especially because some of you may have read in the news, actually they're not a healthcare system, but Anthem, the big insurer, their system was hacked, it was like last month, and 80 million records were stolen. What is that? About a quarter of the U.S. population. And so, and there's many more minor data breaches. And you also have other things, you know, for example, some residents, surgical residents at OHSU got frustrated that the system we use called Epic made it really difficult for them to sign out their patients. So someone came up with a brilliant idea. You know, let's just keep all of our patient lists in Google Docs, and it's sitting up there, and that's exactly what happened. So it turns out if you have a violation of, if you breach more than 500 people, you actually have to report it to the government, which OHSU has had to do 4 times, which is about par for the course for big healthcare institutions. So I gather from the laugh, you know the concerns about that. And then there was actually a couple weeks ago in Science magazine, I don't know if any of you saw this, but there was a group of researchers from MIT that were given basically credit card records that were de-identified, and they were, I can't remember what other sources of data they used now that I'm thinking about it, but they were basically able to use the credit card purchases to essentially re-identify who those people were. So if we're going to put this data to good use, we also have to make sure that we keep it as private and secure as possible. And then before dinner, I was talking to some folks about HIPAA, the medical privacy law, which is onerous in a number of ways, but is not misguided. I mean, there really needs to be ways that we keep information safe. So in my last few minutes, just want to, you can call this a if you will, just telling you what we're doing around big data at OHSU and what opportunities there are. We do have a graduate program in biomedical informatics for people who want to work at the intersection of healthcare and IT. There's an initiative from the National Institutes of Health called Big Data to Knowledge, and we've received some funding. And also at OHSU, we're not interested in being the ivory tower academics up on the hill. We've actually looked at ways that we can better interact with industry, something called the Informatics Discovery Lab. So I'll go through these quickly, and then I'll leave some time for questions. So our program at OHSU is actually one of the largest and best known in the country, and we basically train future professional leaders and researchers. We also have a large distance learning program, and that map, which maybe you can't see too well, all those dots are where our different students live. So people in these different locations can say that they're a student at OHSU, and we're very well known in this area. Again, all at the graduate level, certificate, master's, PhD, and we also do a lot of other innovations in online learning. This course that we call 10 by 10 that provides an introductory overview to informatics. We have a lot of alumni. Well, a lot, I guess, is a relative thing, at least for an informatics program. And we're visible on the OHSU website. I mentioned this BD2K program. Some of you might be interested in this. The NIH in Bethesda, Maryland, which funds the bulk of biomedical research in the U.S., has this new program, Big Data to Knowledge, and they have funded a variety of centers of excellence and also education and training. And we have been awarded 2 grants to develop open educational resources, big data skills course, to disseminate knowledge about big data. And we also do research projects. For example, a project I'm involved with Mayo Clinic, looking at large-scale processing of electronic health records to identify people who might be candidates for clinical studies. I mentioned before, even the seemingly simple task of identifying people who have diabetes, it gets even more complicated when more rare kinds of diseases or people that have different conditions and so forth. And so we're using NLP, other kinds of algorithms to see how well we can identify different cohorts, different groups of patients for research. And then finally, I mentioned that we don't just want to be the ivory tower up on the hill. If any of you attended the Health Ignite talks last fall, I actually spoke there in that weird format that they have. We really are trying to look at ways to collaborate with industry, to disseminate what we do on the academic side, to work with industry, we're, for example, talking with some of the local startup incubators and so forth to see how we can contribute to that. It's not always easy because academic institutions, operate on annual budgets, so we can't really act like a startup company, but there may be ways that we can contribute. So just in finishing up, and then I'll take some questions. So there are plentiful opportunities. There are caveats that we need to be aware of. So we must implement best practices. standardize the data, make it interoperable, and for people who want to do this for a career, there are lots of opportunities. So here's I'll leave this last slide up, which just has a bunch of URLs of our, myself, our department, and some of the other leading entities. And like I said, there's a PDF on my website that has the slides and also the all of those references that I have, which you can track down. You might need to go to the OHSU library to get access to some of them because there's a paywall if you kind of come across the internet. Anyways, I'll stop at this point, and I'll be happy to take any questions as long as people want to ask them. Thank you.